Good morning, everybody. Thank you, Professor Leonardi. My name is Isabella Björkman Burtscher. I'm from Lund, Sweden, and I'm going to talk in the next 30 minutes about central nervous system injuries. I would like to focus on the fact that central nervous injuries are not static events. Even if the impact has happened at the moment, often these are progressive diseases or potentially progressive diseases, and that is something that we have to think about as radiologists when doing our reports on these patients. We are going through central nervous system injuries from top to, not really toe, but downwards at least, and I'm going to start off with head injuries. We can differentiate these injuries in primary traumatic damage and, of course, in secondary traumatic damage. As I said, this disease, if we want to look at it as a disease, is a potentially progressive disease. If we look at the primary traumatic damages, they occur at the time of the injury, and they are a direct result of the traumatic force. And we will go to divide them into the extra and intra-axial traumatic lesions. The secondary traumatic damages are going to occur as a consequence of the primary lesions, and we may prevent them, or they may often be prevented. Traumatic injuries are an important health problem, especially in males aged 15 to 25, but also especially in elderly patients above the age of 75, and this is of course true then for both sexes. The outcome, as you can imagine, varies between a complete recovery and death. These are the extra-axial lesions or damages that we are going to go through, and the intra-axials, and I'm going to into this also. I'm going to mention also shortly the non-accidental trauma. I'm not going to go through all the skull fracture classifications or facial fracture classifications. I just want to remember you that you have to look in these trauma patients for fractures of the calvarian, of the skull base, and the facial skeleton. Be also aware of the terminology. As Professor Parcell already told you, frontal in the brain is not the same as frontal in the bone. So try to really divide these different anatomical areas. Usually we use CT, of course, for the evaluation of fractures in the calvarian, skull base, and facial skeleton. Conventional radiology is not anymore really the method to do it. It's CT. It is very good if you can do reconstructions, if you can do 3D reconstructions. These often look very nice, but however, I think it's mostly for the neurosurgeons to get or the ophthalmology surgeons to get the better overlook, but the diagnosis is often better done on the CT reconstructions. Well, what you have to look for is, of course, the fracture in the bone, but you also have to look for secondary signs, because otherwise you might miss the fracture. You look for intracranial injuries that may be associated to the fracture, to fluid in normally air-filled spaces. You look for fluid air levels, and you have to be careful in patients who are intubated, so severely traumatic patients, because the intubation may lead to fluid levels, for example, which are not associated to a fracture. You have to look for soft tissue damage outside the skull, but also inferior to the skull base, which might lead you to the fracture. You're looking for air in soft tissue and intracranial air. It is also important to sometimes look for foreign bodies. Not that it is so important at the moment of the treatment in the initial phase, but it may be an increased risk for infection if you have actually these foreign bodies left in the skull or even intracranially. If we go from the fractures one level below, then we are going to the epidural space, which is located between the skull and the dura. And the dura is, as you know, or the outer layer of the dura is actually the periosteum of the calvarian bone. And this space is not really seen in a normal patient or in a healthy patient, but you may get these bleedings in this space. Usually they are arterial and are most commonly coming from the middle meningeal artery. However, you may have also traumatic venous epidural hematomas. In imaging, these are usually biconvex or lentiform. They are usually located supratentorially, and they are often unilateral. What you have to consider when you want to differentiate them from the subdural hematomas is that the epidural hematomas usually do not cross sutures, but they may cross dural attachments as the falx and the tentorium. When we look at the imaging on CT, for example, then we have the epidural hematomas often as hyper attenuating lesions, but they may also be mixed or hypo-intense. And what you have to remember is, especially in huge epidural hematomas, the swirl sign or hypodense areas. And these hypodense areas don't mean that this is an old part of the epidural bleeding. It means that this is a very, very acute extravasation in this hematoma. This, of course, makes you to react even faster because this is an ongoing bleeding that is potentially, of course, lethal. When you do look at the epidural hematoma, you would also like to look for the associated lesions, as, for example, the skull fracture, the cerebral contusion, or even the contra-Q, which we are going to talk about a little bit later, subdural hematomas, and, of course, mass effect, as you could see in the image before, where you have a huge epidural hematoma and a huge mass effect. This is a very small epidural hematoma, and of course, if you do the bone windowing, then you're going to see the small fracture. The fracture itself is probably not going, or it's not going to be treated by the neurosurgeon, but again, it might be the outer or front door for the infection to get into the brain, so notice it in your report. Another patient with an epidural hematoma where you have the contra-Q lesion on the other side, so don't only look at the site of the impact, but also on areas more remote. The subdural hematoma, even a layer deeper inside the brain or the head, is a hematoma which is located between the inner layer of the dura and the arachnoid. It is usually caused by a stretching and tearing of bridging cortical veins as they cross through the subdural space to drain into the dural sinuses. The typical imaging finding is a crescent-shaped hematoma. It may be very, very nicely delineated, but also maybe sometimes a little bit more irregular, as in this patient. Again, compared to the epidural hematomas, they cross sutures and extend along the falx and tentorium, but usually do not cross dural attachments, except if you have, of course, a laceration of the dural attachments, then they may cross too. On imaging, the subdural hematomas do very, very much vary in intensity or attenuation, depending on whether you use CT or MR, depending on the age of the subdural hematoma, and you have to take that into consideration. The hyperacute subdural hematoma may be hypodense, and the usual acute subdural hematoma, which we see in the acute situation when imaging the patients, are of course hyperdense as blood is in the acute situation. However, when we then go to the subacute status, we may have iso to hypodense imaging findings, and in the chronic, we usually have hypo or isodense lesions. But however, you have to be aware that there may be mixed densities with both hyper or hypo and isodense, depending on the different ages of the different parts of the subdural hematoma, as you actually can have a rebleeding within the subdural hematoma. The resorption usually occurs within 3 months if you're not operating on these subdural hematomas. This is again the case I showed you from the beginning with the question sign, but however, you see the irregularities, you see the different ages also in this hematoma. This is a chronic subdural hematoma, 5 weeks post-trauma. You can see it here below the front bone on both sides. You can see it then 2 days after operation. You have some air-filled spaces here, and if you look at the coronal slice, you see that there is a huge subdural hematoma, or the chronic subdural hematoma left on the operated side. So you have to look through all the slices, that you really don't just look at this one and then, this looks good, but look also at the coronal slices and go through the skull from the beginning to the end and for anterior to posterior. A problem that we may face in the chronic subdural hematoma are the bilateral subdural hematomas, which is not unusual. And if they start to get iso attenuating to the brain tissue, you may lose it because everything looks symmetrical. You don't have a shift of the midline structures and everything looks fine, but you have to look for the gray-white junction, which is displaced medially, and it is very obvious if you look at that, and then you're not going to miss even these bilateral isodense hematomas. If we go one lower layer below, we are arriving to the subarachnoid hemorrhage, which is, of course, located between the arachnoid and the pile membranes. It is often caused by the leptomeningeal or cerebral vessel tearing in the subarachnoid space, and it may be associated with vasospasm. Also, usually it's below 40% of cases really have a vasospasm associated, but the vasospasm, of course, can give secondary damage, which is important to recognize. In imaging, we have high density in subarachnoid space, as we are used from the aneurysmatic subarachnoid hemorrhages. And what we have to do, however, is to check carefully some structures, as we may have small subarachnoid hemorrhages, and they may actually, even in the acute phase, be rather hypo or iso-intense to the or iso-attenuating to the rest of the brain. So you have to check in the subvenous fissure that you really can delineate it on both sides, in the interpeduncular cisterns and areas remote from the impact. And there it is often in the convexity sulci where you have to look for these subarachnoid hemorrhages. This is a huge subarachnoid hemorrhage, which you most definitely are not going to miss in a patient with a severe head trauma. And this is the course from the initial exam 2 days later and 1 week later. And of course, this patient has been operated on intracranially, and the operation procedure with all the fluid that is inserted in the CSF space is going to wash out your blood faster than if you would have a natural development of this subarachnoid hemorrhage. You have to take into account in your evaluation how the patient is treated, especially if it's surgery involved. This is another case with initial imaging. We see the subarachnoid hemorrhage in the convexity sulci 2 days later and 1 week later. Another case with a interpeduncular bleeding here, which might be missed if you just scroll through the images fast. If you have difficulties to really see the subarachnoid hemorrhage, especially if they are subtle, then you go to MR. And on especially FLAIR images, it is very nicely depicted with these hyper signaling lines on the FLAIR image. And you have the CT on day 1 here, where you can't see anything. Actually, and on day 4, you still see the FLAIR changes. We jump over the brain tissue for a moment and go to the intraventricular hemorrhages and choroid hemorrhages. You shouldn't miss these either. Of course, you may have intraventricular blood as a consequence of a subarachnoid hemorrhage, but of course you can also have true intraventricular bleedings coming from the intraventricular structures or subabdominal structures. And what you're looking for is especially the fluid-Heim level in the posterior parts of the lateral ventricles. And you also look for choroidal hyperdense hemorrhages in the choroid plexus. This is a case with a small blood deposition in the lateral ventricle. You have some subinguinal blood here and clotting at the lateral wall. Another case with a severe head trauma who has a very hyper attenuating lesion here, which is representing the choroid plexus hemorrhage. I'm not going to go through vascular injuries, as these are covered in another lecture, but you have to think about dissections in patients who are suffering from head trauma or especially neck trauma. And if you have symptoms that really don't fit with the imaging findings, you should think about the dissection as a possible cause to the symptoms. We go back to the brain parenchyma. We start up with the cerebral contusions. It is a brain damage involving the superficial gray matter. The location may be on different sites in the brain, either on the Q lesion side or the Q side. This means the impact side from main force. And you may also look for the contra Q. And usually this is defined as a lesion at the opposite side from the impact. induced by the gyral crest and striking fixed surfaces. But however, if you have a fracture on the right side, that doesn't mean that the contracure must be on the left side, because if you have, for example, a tangential force that really gives your brain a movement in the vertical direction, for example, you may have contracure lesions also in at the same side, but remote from the impact. So don't just look across the images, but look also at other sites in the brain. If you have depressed skull fractures, of course, you should look for the cerebral contusions in adjunction to these fractures. Where do we find the cerebral contusions? Mainly we find them in the temporal lobe or frontal lobes, especially in the anterior temporal lobe and the basal areas of the frontal lobes, due to the surrounding structures of the calvarium and the skull base. We find them less commonly in the parietal, occipital, or infratentorial regions. Cerebral contusions on CT, you usually say that contusions are hypo, attenuating due to the edema that you see. They may have involving hyper-intense lesions representing a particular hemorrhages or even larger hemorrhages. But you have to be aware of that cerebral contusions may not show in the CT for the first, let's say, 24, 48 hours or even longer. So a initial negative CT does not exclude cerebral contusions. And this is something you have to be aware of. And we are going to go through some of these cases also in the workshop. So this is a case with the initial CT, and then you can see how the contusion evolves over time. Of course, you will have a tissue damage here, and you get an atrophy. You may even have a large atrophy in a larger area, not just in the area where you can see the bleedings or the edema from the beginning. Another case, 6 hours after trauma. That's how we looked at 6 days after trauma. This patient has not been mistreated at the neurointensity care. That's just the evolution of the cerebral contusions in this patient. If we have difficulties to really see the cerebral contusions, we go further on with MR if it is important for the clinical evaluation and treatment of the patient, and then we do FLAIR imaging for the hyperintense cortical edemas, but we also do, for example, gradient echo images to see the hemorrhagic foci, or even the more modern methods as susceptibility weighted imaging are going to depict the hemorrhages very, very nicely. Intracerebral hemorrhages may also occur, larger parenchymal arteries or venous vessels that are damaged. They are usually located in the white matter, most often in the frontotemporal parts of the brain. This is an example, and you again see the development over time, which you often can see and which you have to describe in your reports in these patients. These patients, of course, have also other brain lesions. The diffuse axonal injuries, traumatic axonal stretching injuries, also called, the definitions vary between the different textbooks. What is important is that they are often multifocal. You often have punctate hemorrhages also if you can't see them, sometimes neither on CT or on MR. They may be microbleeds, which are very, very small. The dye changes often involve the corticomedullary junction, often in the frontal or temporal lobe. Here then often parasagittal or periventricular. The corpus callosum is an important structure to look at, and the deep gray matter with the internal capsule on the upper brain stem. You may not see anything on CT. If you see something, you often see hyperdense foci if you have hemorrhages, or you see a hypodensity responding to an edema. On MR, which is more sensitive, much more sensitive, you see the hypointense foci on gradient echo images or the susceptibility weighted imaging for the bleeding, or the diffusion weighted imaging you also can use, and then you use, for example, the B0, which is again sensitive for susceptibility artifacts. This is a case. You have changes in the frontal white matter also here, but you have several changes along the white matter in this case. Sometimes it's obvious on CT that you have these steep changes, and if you do the MR, of course, you have corresponding findings to these lesions. Sometimes it's very, very difficult to see something. As I said, on CT, you may sometimes suspect that there is something. If you look at this, especially corpus callosum, try to do coronal reconstructions because it's much easier. You don't have the parched volume effects that you get if you do the axial reconstructions. And if you go then through the MR, you can see these extensive changes located in the corpus callosum in this patient with severe deep axonal injuries. As I said, susceptibility-weighted imaging may be very sensitive. You don't see anything on diffusion-weighted imaging, nothing on FLAIR, but if you do susceptibility-weighted imaging, you can see 2 dots here. You have to be careful that you don't misinterpret vessels, that you just cut in the trans or in the axial slice. So follow them up and down so that you're not misinterpreting tubular structures as bleedings. And if we listen up, we have 2 bleedings in the basal ganglia and the thalamus. If we go into the deep structures, the brainstem, basal ganglia, thalamus, we may also have the subcortical injuries, a bad prognostic factor in trauma patients. And it's again bleedings and edemas, which we are looking for with the same techniques, CT, often negative, or MR, which is much more sensitive. This is a patient who didn't wake up after trauma, and what we could already see on CT is a traumatic brainstem injury. And this is another case. You can see the injury in the brainstem and also extending out to the cerebellum. Penetrating injuries are often very obvious. What's important with these lesions is that you can have all the different damages and brain injuries at the same time. It is important to really report them, and especially with the thought that this might be a progressive disease and that you might actually have complications related to these injuries, which we might not suspect in the beginning. This is just an example of a penetrating gunshot injury where you have all the different injuries at the same time. Non-accidental traumas, I'm not going to go through it because it's an own lecture for itself, but you have to remember that non-accidental traumas occur, especially if you're dealing with traumatic brain injuries. Whenever you see a combination of scalp injuries, multiple fractures, intracranial hemorrhages, especially if they are of different ages, if you have a combination with cerebral contusion, sharing injuries, or ischemia, you should think the thought, non-accidental trauma, or if there is a discrepancy, of course, between the trauma or the description of the trauma and the findings. However, you have to consider that there are differential diagnoses, and that's actually the accidental trauma, so don't overinterpret things, and you also have to think that there is actually an uncommon differential diagnosis with diseases like coagulopathies, metabolic diseases, for example. What you also should think about is the late sequelae that you might see in a patient like hydrocephalus, encephalomalacia, or atrophy, leptomeningeal cysts. If you see these things and can't explain it from the clinical history, again, think the thought and try to find out whether it could be possible or not. The secondary brain injuries is a long list, and you could even continue with it. And we have to think about that from the beginning, and sometimes, of course, we are encountering them in the therapeutic phase of the trauma. We have to think about vasospasm, hypoxia, ischemia, for example, as a secondary change to a dissection, edema, mass effects, herniation syndromes, intracranial hypertensions, iatrogenic damage may occur, atrophy, and so on. Let me give you some examples. This is a patient with a neck injury. There was nothing on CT on the neck, no fractures, no soft tissue damage, but of course the patient had a ICA dissection, and the patient suffered from a stroke in this area, or an ischemia and an infarction. This is a quite usual complication, the hydrocephalus in patients with especially also intraventricular bleedings, which may ask for surgical treatment with a shunt. This is the herniation syndrome. If you have a swelling of the brain tissue, of course, you may have severe problems for the patient. It may lead to death, and it is important to think about that, especially in young patients, initially in normal CT, but you have to think contusions may evolve, they may have a mass effect, and they may lead to the herniation syndrome. So this is also important that you think that it is not unusual that we do CTs quite frequently in these patients to exclude that the herniation syndrome is occurring. iatrogenic changes. This patient had a chronic subdural hematoma. The neurosurgeon tried to drain it. The drainage didn't really end up where it should. You might laugh. It is extremely difficult to get this drainage in the right position because there are lots of tight membranes in these chronic subdural hematomas. And of course, you have to put it out again. But things like that you may see, and you have to interpret it in the right way. Sometimes neurosurgeons put in things that you wouldn't expect. This is, for example, not a bleeding, it's a microdialysis catheter. So you have to think on what has been happening to the patient between the impact and the follow-up CT, for example. In the last 5 minutes, I'm going to go through the spinal injuries. Again, fractures of the spine or the column are classified by different systems. I'm not going to go through the different systems. What you should think about is what happened to the patient, the type of injuries, flexion, extension, vertical force, or miscellaneous force, and try to find fracture types that really fit with that. Go for the probability of instability. This is very, very important. Is this a stable or unstable fracture? And of course, think about dislocation. And sometimes, or very often, the dislocation is not visible anymore when the patient comes to you because it has been repositioned. But think about the lesion. If it's an unstable fracture, could there have been a dislocation and a spinal cord injury due to the dislocation? What are we looking for? We're looking for soft tissue injuries, paraspinal muscles, perivertebral hematomas, and this you can't only do on MR. Of course, you can do that on CT. Sometimes you see huge bleedings on CT if you just window a little bit on your skeletal reconstructions. You anyway can see the soft tissue quite well. When we go to the spinal cord, we have to suspect spinal cord injuries? The thing to validate this is, of course, CT on one hand, but also MR. We are looking for discrepancies between symptoms and findings. The patient has nothing on the CT that looks strange. However, the patient is plegic, for example, then you, of course, have to go further on with MR. One important thing is a late worsening of symptoms. The patient initially was fine, maybe some neck pain, but nothing special, but then neurological symptoms are occurring. Go to MR. And of course, we want to have a look before surgery. What might we find? We might find disc herniation, hematomas, cord contusions or hematomas, cord herniations, very seldomly found, or dislocations in the lower and cervical upper thoracic spine. This is, of course, if you do conventional radiology, conventional x-rays for especially the cervical spine and you miss the damages just below the C7 level. And then, of course, you're hopefully going to detect that on CT. The MR in cord contusion, what you're looking for is abnormal signal in the cord, parenchymal T2 hyperintensities. And the stir sequence is a very helpful sequence because you can see the bone marrow edema, the hypertense ligaments, and the tissue injuries. And what you also would like to do is to then go through the cord and, for example, look with more specific sequences as T2 star gradient echo sequences and look for cord bleedings. Disc herniations, this is the initial CT. We have the initial CT, sorry, is here. We have a huge fracture. There was no dislocation of the vertebral bodies. The MR done afterwards, you can see this disc, which is not really feeling well. And of course, this disc doesn't really give a damage to the medulla in this case. We don't have a medullary edema, spinal cord edema. But anyway, of course, it has to be stabilized and the disc had to be taken out and replaced by a cage. Dural and vessels, we are looking for epidural, subdural hematomas, dural tears, arterial dissections, hematomas, and in the late evaluation also AV fistula. So if we think about the CNS trauma, it is a static event that happens at the injury, but the disease that is following the event is possibly progressive and may lead to more severe damages and suspected in the beginning. A good knowledge of the typical trauma and injury patterns makes diagnosis easier. Don't be happy with finding one injury, try to find all the injuries. And the prevention of secondary brain damages and complications and long-term disability, of course, are the major aims of the treatment. And it is important that you think about that when reporting on these trauma patients, because you sometimes have to be one step ahead the clinicians who might not see the whole spectrum. And a very important message, I think, is that CT and MR should be used generously in CNS trauma. Don't rely only on conventional X-ray, for example, for the spinal column, because you may miss a lot. And with that, I would like to thank you and look forward to the workshop and go through some of the cases. Thank you very much.